All right. Thank you everybody for taking the time to join. A big welcome from us here in Geneva. My name is Sarah Hess. I work in the Department of Global Infectious Hazards Preparedness at WHO and the Health Emergencies Program. Very happy to be here today hosting this webinar alongside Rosamund. So I'm going to hand over to Rosamund now to make a few opening remarks, and then we're going to introduce our very distinguished guests that we have on the phone with us. Rosamund, over to you.
Yes, good afternoon. Thank you, Sarah. We are in the same room, but we are physically distanced as we must be today. And we welcome all of you. Oh, hello, John. We've got you on video. Can you hear us?
Yeah, I can.
Perfect. We can't see your face very well. If you could lower your camera, it would be terrific.
Will do.
Thank you. So we're delighted. This is a really momentous occasion. The 8th of May, 1980 was the day that the World Health Assembly declared the eradication of smallpox, one of the most feared diseases, scourge of humanity that had certainly affected many lives through 3 millennia. But today I would just like to first welcome all of you who have been instrumental at the core of this program. We are here now holding the fort, but you are the ones that got the job done. So I would like to hand back to Sarah to introduce each of you. And we would like to welcome also our surprise guest, Dr. William Fagey. We are so thrilled to have you with us. It's wonderful. So we will also try and introduce you at the best of our ability. Please, all of you, this will be more of a conversation. We have just a few slides at the beginning to set the stage, because we do have upwards of 100 people, and the number is rising every moment online. This has been a very successful series of webinars here from the EPI-WIN team, the WHO Health Information Network for Epidemics, and we've been doing webinars 2 or 3 times a week throughout the COVID outbreak in the last several months, well, 4 months already. But today we thought we'd make it a special for this special day, 40 years since smallpox eradication. So Sarah, please introduce our guests, and then we'll go through some slides, and each of you will share your experience with us. Thank you.
Thank you. So this could potentially take a long time, because we have very distinguished people on the line with huge and impressive careers, but I would like to introduce now. So Dr. Ghassan Suleymanov. Dr. Ghassan started his career in WHO in 1972, where he was assigned as an epidemiologist to Pakistan to build up the surveillance for smallpox. Ghassan then moved on to Ethiopia, where he continued this work. And afterwards, up until the end of his career in 2010, he was a scientist and a staff member of the epidemiology branch of Marcinovsky Institute in Moscow, where he was in charge of malaria control campaigns in endemic countries and working as a WHO epidemiologist. So welcome, Ghassan.
Thank you.
We also,
First, may I start?
Let me go through, and I'll introduce the guests, and then we will come back to you. Thank you very much.
Okay.
So we also have with us Robert Steinglass. Robert Steinglass began his public health career 47 years ago as a foot soldier for smallpox eradication in rural Ethiopia, and then as a WHO technical officer in the Yemen Arab Republic, to collect evidence on the absence of smallpox as part of the global effort to certify eradication. For WHO and then for John Snow Inc., he technically supported ministries of health to strengthen immunization programs in nearly 50 resource-poor countries around the world, predominantly in Africa, Asia, and also provided technical support at a global level to WHO, UNICEF, Gavi, and others. Welcome, Robert.
Thank you.
Another guest that we have here, John Wickett. Welcome, please, John. So John grew up in Vancouver Island in Canada. He attended university at Victoria College and the University of British Columbia, studying mathematics and human genetics. He came to Europe in 1969, where he celebrated his 25th birthday, roaming around with a friend, a guitar, and a motorcycle. He joined WHO and the Smallpox Eradication Unit in December 1970 as a junior technical officer. With the eradication of smallpox, he remained with WHO, retiring after 34 years as Budget, Program and Planning Officer. Welcome, John. We also have with us David Heyman, who is currently Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine and head of the Centre on Global Health Security at Chatham House, London. From 2012 to 2017, he was chairman of Public Health England. For 22 years, David was based at the World Health Organization in Geneva on secondment from the Centers of Disease Control and Prevention in the United States of America. Before joining WHO, David was based for 13 years in sub-Saharan Africa on assignment from CDC, working on the response to the first, second, and third outbreaks of Ebola in the DRC and on human monkeypox outbreaks. Prior to joining CDC, David worked in India for 2 years as a medical epidemiologist in the WHO Smallpox Eradication Program. David is also a distinguished fellow in the Global Health Program at Chatham House in London. Welcome, David. We also have with us Marie-Sarah Villemin-Pauteau. Marie has been with WHO since 2003 as a WHO archivist. Marie implemented and rolled out the External Researcher Program and the Smallpox Digitization Program. After a stint in the WHO Western Pacific Office, Marie returned to headquarters in a role as Head of Records and Archives. Welcome, Marie, and thank you for joining us. We also have with us a surprise guest, Dr. William Fager, who I believe can be credited in part for devising the global strategy that led to the elimination or the eradication of smallpox. William, we're very delighted to have you on the line, and I hope that you will tell us more about this role later on in the program. So thank you all to everybody for joining. I'm going to hand over now to Rosamond, who will give a few introductory remarks. If our participants have joined by their computers, they should be able to see my screen, which I will share now as we have a few slides. Rosamond, over to you.
Thank you very much. So these are short slides, but we have, as mentioned, many guests sharing this moment with us online who may not have the same level of understanding as our panelists. So I'm very happy to give a brief overview of what is or what was smallpox. So smallpox was in fact a terrible disease, as mentioned, characterized by high fever, prostration, fatigue, backache, headache, but most characteristically a terrible rash, which would begin be most prominent on the extremities and develop into very painful vesicles and pustules, which could even coalesce over time. So the pictures you've seen are of children or of people with rash all over their body. This was a highly infectious disease, respiratory infection, much the same way in some respects as COVID is today, with a similar R0. You know that the R0 is basically the indicator of how infectious a disease is, as to how many people the one person who's infected can otherwise infect. And it's for COVID-19, we think it's around 2 or 3 at the moment. It remains to be elucidated. For smallpox, it was thought to be around 3.5 to 6. So in the same order of magnitude of infectiousness, less infectious than measles, but more infectious than other diseases. Unlike COVID-19, which has also, well, it has a 2 to 14 day incubation period, but generally the average is shorter, around 5 to 6. For smallpox, it was a longer incubation period, and people were not really infectious until they actually became ill. So we've already talked about the clinical syndrome, but as people recovered from smallpox, after those who recovered, so about 2/3 of people did recover, they would also develop complications such as blindness due to the rash or the lesions affecting the eyes, pneumonia, of course, as well, being a respiratory illness, and arthritis, and sometimes lifelong disfigurement. Luckily, well, for us, over 200 years ago, English physician named Dr. Edward Jenner, he's described as a country doctor who looked after people with smallpox, but also were living in a rural area. He managed to discover or create what became the smallpox vaccine. At the time, it was noticing that young milkmaids who often had cowpox on their hands were actually never affected by smallpox itself. And so he took some pustules from the hands of the milkmaids and inoculated other people, or a boy actually, with that otherwise relatively benign illness, and managed to demonstrate that the boy was protected from smallpox in ways that may not be quite the type of research we would do today, but certainly was very effective. So we've had a vaccine for over 200 years. Yeah, so that's fine. So smallpox had been around, as we say, for over 3,000 years from the time we have pictures of the mummy, Pharaoh Ramses V, with smallpox lesions over his head. And that was ascertained, obviously, by anthropologists. And it was already a big killer for a long, long time, until the 20th century, when even in the last century, 300 million people died of smallpox. Now, when you consider that this was actually in the first 3/4 of the century, from 1900 to 1975, you realize that that's an average of 4 million deaths per year, although probably most were in the early part of the century as the vaccination programs progressed and improved around the world. Still, comparing to what we're experiencing today, we can see the burden that this presented for populations around the world of an average of 4 million deaths per year. So in 1958, the Russian delegation to the World Health Assembly proposed global smallpox eradication. And this was, had already been discussed from the very first, smallpox as an issue had already been discussed from the very first World Health Assembly in 1948. But now the Russian delegation came forward and basically proposed that the world undertake this final push. So that was agreed. And after another few years, it was determined that they needed an additional effort to accelerate the pace. And in 1967, the World Health Assembly launched the intensified smallpox eradication program and tasked the WHO Secretariat with coordinating this effort. I think Dr. Fege will also be able, and Mr. Wickett will be able to tell us more about that. So what was characteristic about this program at the time, and these are some of the things that we want to think about today as we're battling this new incredible disease, COVID-19, is at the time that the response was characterized by global cooperation between countries, surveillance, house-to-house case finding and contact tracing, but also notification to WHO of all the cases that were identified. Of course, we needed sufficient high-quality vaccine. At the time, vaccine was made by many countries in many different ways. It was a live virus vaccine, and so there were significant quality, access, and supply issues which needed to be addressed. And then at the time, there was some vaccination in routine childhood programs in richer countries, but in many places where the virus was still, the disease was still endemic, efforts were made to undertake mass vaccination programs. But of course, then there wasn't enough vaccine. So this led to the new strategy, which Dr. Fege will tell us all about, the ring vaccination strategy, which is still used today for Ebola. At the heart of this, and less often mentioned, are effective communication campaigns that took place. Marie will show us some of the posters and things that were used at the time. I think we can go to the next slide. And this is my last one. Well, just to say that the last known cases were in Bangladesh in 1975 for variola major, and variola minor was in Somalia in 1977. And then, of course, we did have a couple of cases in Birmingham in England due to a laboratory accident, which then led the world to also contain the remaining virus into the 2 laboratories at Vector in the Russian Federation and CDC in the United States of America. And so that is where the remaining stocks of virus are housed since that time for research in those 2 locations. But since then, there have been no further cases reported or documented anywhere until 40 years ago today, the World Health Assembly declared smallpox eradicated. So we just want to say one more thing about the communication, which Marie will elaborate on. Basically, at that time, it was equally important to get the right information to the right people in the right way at the right time. This is what we try to do today. We'll get to that in a moment. But at the time, it was picture cards to recognize cases, distinguish between smallpox.
They hoped that success could be achieved dancing from results of CDC campaign in West Africa, where our friend Ferge and Dr. Henderson demonstrated good results. So they were absolutely sure, I mean American side, that smallpox could be controlled and wiped out. There were several series of communications, consultations between the top brass in Ministry of Health of USSR and the United States. And it was lucky, I think, coincidence that at that moment, all necessary prerequisites were already available. First of all, Russia finally succeeded in producing a really powerful, potent, standardized freeze-dried vaccine. And they been able to produce vaccine in quantities. Then Americans invented bifurcated needle. Very important moment. It was a rapid, safe method of introduction of vaccine. So combination of these factors will laid in the basis of the future success. Of course, both sides, they try to gain some purely political benefits from the future success. Each of them had their own interests, but in this point, their interests coincided, luckily for mankind, luckily. So, in fact, there were formation very unique, I would say. The reasons to the means of control were at hand: potent vaccine, good method of introduction, and efficient management. It was a very important point that the most suitable person was selected to as the chief of Smallpox Eradication unit in WHO. It was Dr. Henderson. For me, no need to publicize this person. All of us know him, perfectly know, and know his qualities. I doubt that there would be any other person more suitable for this position. You know, it was so many people involved. According to last estimates, 3,000 people were directly involved in the control operation. 3,000. 600 of them were internationally recruited. How he was able to manage, for me, always was a secret. Yeah. You know, I was always have a feeling he's breathing in my neck, you know. By time, you know, I was so shocked receiving from him handwritten letters on many pages where he discussed with me details of control operation of outbreaks. You can imagine. Yeah. And I have here in my room next door archive. There I have still 19 papers from him, from Henderson, you see. It was fantastic. So, but I was not alone in the field. Yeah, 600 foreign epidemiologists of different level, of course, yeah. But 600 he was able to control, to direct, you know. So this is very important. The management is a basic and very important rule for any control campaign. So this is, I would like enough to explain why we entered in this, I would say, heroic, dramatic, fantastic story. I always recollect this my movements, you see, sometimes with skepticism and being a bit, how to say, puzzled, because, you know, from in the distance of 50 years, you can't believe that it was me. So being in so absolutely impossible to describe situations, you see, as all of you. So for me, it's really good and nice, the unique experience of my life. Thank you.
Thank you so much for sharing with us your thoughts and experience about the very bold decision of proposal in the face of huge obstacles. And I think really important points that you mentioned on the combination of having very dynamic and effective leadership and management, also the coming together of advancement of technologies, both within the development of the vaccine and the bifurcated needle, but again, also the scale of the undertaking, which was so impressive. So thank you for that. I wonder now if we can turn to William, who can give us an idea of some of the planning and the strategy that went into this, this global initiative. William, over to you.
Thank you very much. Some of the aspects have already been mentioned. I'm glad that we've heard about how the Soviet Union took the lead on this and how they talked the United States into joining them in order to convince the World Health Organization this was worth doing. And I'm glad we heard a little bit about the history, because we have a hard time remembering how difficult this disease was for so many. And Voltaire, you know, had smallpox and made some calculations at the time that he expected about 60% of everyone born in Europe would get smallpox. And a third of them would die, a third would have pockmarks for life, and only a third would get away scot-free and totally recover. So it's been a difficult disease forever. We couldn't see the future. We couldn't have guessed that at the 40th anniversary, we would be in the midst of another outbreak and asking, what did we learn with smallpox? Well, one of the things we learned was the importance of knowing the truth. If you cannot know what the truth is, you just don't know what you're doing. And that lesson seems to be lost, at least here in the United States, when it comes to COVID-19. We need to know the truth. And how do you get the truth? By a surveillance system that lets you know what is happening. And so I have the feeling in the United States right now, we're experiencing a remedial course in humility that we simply have not used the lessons that we learned in the past. With smallpox, one of the things I remember is how hard the work was and yet how enjoyable it was. There really was a feeling of people working together, huge numbers of people working together. You ask about the strategy and how that was developed. And I try to always make clear that in West Africa, we did not come up with a new strategy. what we did was remove half of the old strategy. So the WHO approach at that time was you first do mass vaccination, and then you concentrate after there's a reduction in cases on the outbreaks. Hassan mentioned this idea of if we got to 80%. So people talk about herd immunity, and as they do, they forget that herd immunity is just a figure about what's the probability of something happening. And the higher you get on the immunization list, the lower the probability that you'll get the disease. But there is no immunity level that actually works for everything. We demonstrated this in Nigeria when we reached 93% coverage in one area, and they developed a smallpox outbreak. And then in another area, we were able to stop smallpox by only vaccinating 7% of the population. So we have to be careful with herd immunity. We also, as people talk about herd immunity, they forget to say it has a relationship to population density, that it's really the number of susceptible people within some area that is important. But going back to the lessons, know the truth, do surveillance. In order to do surveillance right, you have to come up with the most accurate numerator and most accurate denominator that you can, and then you have to interpret that. And in West Africa, we found that if you concentrated on trying to find where the virus was, and then get, quotes, herd immunity around that person, that's the way you could stop smallpox, and you didn't have to start with a mass vaccination campaign. And so we did a lot of contact tracing, and we did it at such a high level that it always surprises me that people now say we can't do this with COVID-19. For instance, in May of 1974, in Bihar state alone, they were having 1,500 new cases of smallpox per day. And that means that we were doing 1,500 new investigations every day. We were finding the person, we were isolating them, we were putting watch guards on the house, we were asking about their contacts, we were finding out if their contacts had smallpox. And so at a time before computers, we were able to do things that were so labor intensive, they should be possible to do now with COVID-19. But lessons get lost over 40 years and 50 years. So I'm glad we're now talking about 40 years with no smallpox and what can we learn about COVID-19. Thank you.
Thank you so much. Some very clear lessons there that I think are on the forefront of everybody's minds at the moment. One of the first points you made, however, on finding it hard to remember accurately the burden of this disease 40 years later, perhaps that is a good segue to you, Robert. I think you've published a lot and tried to document a lot of the stories around this. And I wonder if you can share some of that with us today.
Thank you very much. So I had a bifurcated experience in smallpox. I worked both in the Yemen Arab Republic, which in those days was called North Yemen, at the tail end of the process to prove that smallpox didn't exist in North Yemen. It was one of the last 6 countries in the world that still had to be documented as having had no smallpox. And there in North Yemen, I was a WHO staff member, and I designed and implemented with the Ministry of Health that nationwide search. So I played a fairly large role in North Yemen. But at the beginning of my career, 5 years earlier, I started in Ethiopia. And that's, for me, that was a transformative experience because I was 23 years old. It was my first exposure to public health. So I really lucked out to be assigned as a US Peace Corps volunteer, assigned to WHO, working with the Ministry of Health on their smallpox eradication program. And you know, every country is different. I can only really speak as a foot soldier in Ethiopia what my experience was there. I was assigned to the northern part of the country, Wollo province, as it was called at the time. Very high mountains, up to 11,000 feet. I also worked below sea level in the Danikal Desert, which is the hottest inhabited place on earth, I'm told. So it was an arduous experience. 3 weeks in the field, basically, whether you liked it or not, climbing mountains every morning, looking for smallpox. 1 week back in my base, which was Dessie, the capital of Wollo province. I could be wrong, and Bill would be the right person to correct me on this one, but I think that Ethiopia might have been the only country, or certainly maybe the first country, that exclusively relied upon surveillance and containment, the strategy that he has described, to eradicate smallpox. There had been no real mass vaccination campaigns in Ethiopia. Ethiopia had a form of variola, which was called variola minor, with a case fatality rate of about 1%. So the disease wasn't as feared in Ethiopia as it was in many other countries. And consequently, I think Ethiopia was the last endemic country to join the smallpox eradication program. I was a surveillance officer. My job was to basically search for cases, search for recent evidence of cases, trace contacts, and do ring vaccination around any cases that I found. And here's where the old biblical adage about seek and you will find, or seek and you shall find, is relevant, because the Peace Corps volunteers played an important role in Ethiopia. Up until then, there hadn't been a lot of searching going on. In fact, I should mention that John Wickett on the call here was the man administratively responsible for my recruitment when I joined WHO later in Yemen. But in Ethiopia, we, I think the year before the volunteers came, the year before Ethiopia joined the smallpox effort globally, there were just a handful of cases that were reported. Within a year, or during that first year of the involvement of Peace Corps and the engagement of the program into the smallpox, into the WHO effort, I think 26,000 cases were discovered that very first year. So those cases there had always been cases. It just, if you didn't look, you weren't going to find them. And I think there's parallels there with COVID-19 in my country, in the United States as well. Most of the population where I worked in Ethiopia, 80% of them lived more than a full day's walk from the nearest road. So everything was done through walking or using mules or, to get up into the mountains. I was 1 week or more from the nearest telephone for most of the time that I spent in the field. And yet, as Bill said, so much could be achieved without modern methods of communication. We encountered a lot of resistance. Where I was the area where there was a point in 1975 probably where if you were to overlay a map of where there was smallpox in the world and where Amharic was the principal language spoken, they were exactly the same spots. There was this great culture that I loved. It's what appealed to me. It's why I joined Peace Corps. I said I'd only go to Ethiopia. They sent me to Ethiopia. But this was a very strong culture that was highly suspicious of the idea of smallpox vaccination. Wellness and illness was something that was provided by God. There was divine explanations for everything. And for a 23-year-old to sort of stumble into a village that had never seen a foreigner and say, if you just vaccinate with this smallpox vaccination, you'll be prevented from smallpox. It was really blasphemy. We were not always well received in the northern part of Ethiopia. The southern part of Ethiopia, people were received with open arms by the local population. The good thing was that with smallpox, people were not infectious during the incubation period. So all you had to do was to look and use your eyes and go to markets and go to schools and go to religious gatherings, and in my case, famine relief camps, with the picture of smallpox and say, has anybody seen people who looked like this, because you were only infectious when you were visibly with the disease. So we had something to look for to do our searches. And if I could just say one last thing, this was such a transformative experience for myself and for other fellow 23-year-old Peace Corps volunteers that on the occasion of my supervisor and our supervisor in Ethiopia, a really great epidemiologist, Dr. Cyril de Quadros, who passed away in 2014, we came together in Washington to commemorate his life, and we decided to write a book. And D.A. Henderson, alive still at the time, agreed to do the foreword of the book. And we used a chapter in the book that Cyril de Quadros had written about the experience in Ethiopia. So 15 of us volunteers wrote 21 chapters, and this is a shameless plug, but the book just came out, and this is probably backwards. Are you reading this backwards?
I have.
You have a copy, you guys.
I have a copy, yeah.
It's called Eradicating Smallpox in Ethiopia, and this is possibly for the...
yeah, I read it with pleasure. Yeah, it was really nice reading.
And it's an account of the Peace Corps volunteers' experience, their adventures, challenges, and achievements. So it's a very vivid, firsthand account and a very personal account in a memoir style about what it took to eradicate smallpox in Ethiopia by people like myself who were pretty clueless entering this, but we were asked to do a lot, and I think we delivered. Thank you.
Thank you so much, Robert. I think we can only say thank you for taking the time to document and share those stories, and I look forward to reading the book. I'll be on to Book Depository before the day's over. I think important that we capture these stories about the huge sacrifice, not only on a personal level, but for a global eradication program, it must have taken a huge amount of resources. And I'd like to move over to John now, because John, I think, spent a lifetime at WHO in the financing world. As you mentioned, he was involved in your recruitment, Robert. So, John, I wonder if you could share with us some thoughts about and some insight into how was this global movement funded and sustained? You're on mute at the moment, John. You may have to unmute your mic. I can try. Let me try. Try now.
There. Is that should work.
Perfect.
Good.
We hear you well.
Well, Robert really covered some ground that it was a lifetime, a once-in-a-lifetime experience, just incredible. And certainly kept me going for the rest of my career in WHO. I could always look back at things that had happened that were good. And I was noting down a few things that I could touch on. Well, we had the big red book, and it has everything you ever wanted to know. But we also had a whole series of these World Health magazines, and we all had articles on smallpox, and I can recommend them for archiving if they aren't there already. They have lots of good pictures and lots of stories for the layman. One anecdote I just cannot resist, it's just to do with Bill Fagey. And they were doing the surveillance containment, it was necessary to get people in the village and come and get vaccinated. And they were having troubles, as the story was recounted to me, until Bill showed up And then people went around announcing, hey, come and see, this is the tallest man in the world. Remember that, Bill?
I do.
And the other anecdote, which was sort of a Faggy, only Faggy style could bring it off, was the way you managed to get lots of legroom on aircraft. Because Bill, as we know, is very tall. And so he would come in and get a window seat and immediately pull out the barf bag and hunch over. And nobody wanted to sit next to him for some reason or other. And he had lots of legroom. Anyway, so touching on surveillance containment, this was obviously the way to go, but in order to implement it, we had to get to the outbreaks and do excuse me. So in order to do surveillance containment, you had to find the cases, go visit, do the housework, the revaccination, and do the contact tracing. Now, this is one problem, and I think we have to attribute this to doctors. Most doctors had I get blanks. Old age is settling in. Yeah. So one of the real problems we had in Bangladesh and India was the people had to get to the outbreaks and then to do the work for them. And the problem was we were dealing with doctors, and doctors sort of a chronic aversion to money and paperwork, but this was necessary. And in other words, the whole surveillance containment thing rested on having vehicles and being able to get to outbreaks. Now, this comes to one anecdote for solving the problem of, well, in Bihar, there were 150 vehicles, and they all came to Patna to get serviced once a month for the monthly meeting. And this overloaded. We had some Catholic brothers who had a workshop and they could do what they could, but I mean 150 vehicles. And that resulted in people coming to Patna and not having a vehicle functioning. And so they just sat around Patna and weren't going out doing the surveillance containment and contact tracing. So I thought about this, and it turned out the problem was that the youngsters, the young doctors, that we would give a car, a driver, and some vaccine and go out and do the job. They were afraid to spend money, even though they were given money, because, well, that was just the situation where people were very sensitive, very hesitant about spending money. One had to be very careful. So the answer was, I simply sat down with one of the Catholic brothers and made a whole list of standard things that you had to do. You had gasoline, oil, fill up the tires, change the spark plugs, whatever. And I said, there's the list, and those are the prices. When your driver says this is a problem, get him to do it and pay that price. And then there was no problem anymore. we could enjoy ourselves at the monthly meetings and then send everybody back to work. The ultimate logistic problem that was solved was the helicopters for Ethiopia. That really made a difference, which Robert can, I'm sure. Did you get to ride in those critters?
Robert, you're
No.
on mute, unfortunately. Sorry.
Well, he's out the
I
same
was just
problem
saying
I
that
had.
unfortunately the helicopters came a little bit too late for me. I wish I had been
Me too.
my helicopter.
Well, yes, there was one with Bill Waugh was taken, who was a pilot engineer, who was captured and tried to ransom him, but he managed to talk his way out of it, like a good Canadian, anyway. And we had one other helicopter blown up with a grenade because at the time there was a war going on between Ethiopia and Somalia. But when we thought we had found the last case in Ethiopia, but it turned out that there were still cases occurring in Somalia. So we said, well, what are we going to do about, there is a war going on, there's no health services, no structure whatsoever, it all has to be added on. And we couldn't get any Land Rovers from the factory, and we said, well, what are we going to do? And we've got to do something. And I remember Jock Copeland, who unfortunately isn't here, said to me, said, John, there is no Santa Claus, you know, where do you think you're going to get this stuff? And I thought and remembered when I was in high school that the fellow who sat behind me became a fighter pilot for the Canadian Air Force. And as such, he had to put in X number of hours to stay licensed, whatever. And he used to fly back with a trainer jet to Toronto from Vancouver Island to visit his girlfriend, who was a nurse. So now that means that someone has to fly X number of hours, and they had a military flight where they had Hercules. And so I phoned the Canadian mission and said, did you have any Hercules you could spare to take some Land Rovers, which we have discovered have been reconditioned in Denmark or something for UNICEF? Anyway, we managed to get the case in Somalia, turned out to be a case for declaring the country a disaster, because there's separate funding for a disaster at the discretion of the representative in a given country. And so it turned out we got 7 vehicles airlifted and a bunch of spare parts and supplies and funding in response to declaring themselves a disaster. And that was the end, actually. We made a film called The Search to support our contention of the fact that there was no more smallpox left in the world, which was the certification procedure after which led up to today, the 8th of May. I have any number of anecdotes one thing I can say, that Rosamund, she's heard it. I used to tease DA. He said that he spent all that time putting together a book, the Big Red Book of 1,700 pages, whereas I, playing Bob Dylan, composed a song called Variola Blues, and that recounts the whole history of smallpox eradication.
Yes, we can play it for you if you like. It's on YouTube.
Yes,
Great.
it's called Variola Blues, and it comes up. So life, well, was wonderful. It was an amazing experience. And
Yeah, if I can, you just mentioned about transport. As a rule, we used horses and Land Cruisers, and in headquarters in Addis, yeah, it was a rule, established rules, that all WHO epidemiologists should use brand new Land Cruisers, but with zero on speedometer. We were permitted to use these cars up to 30,000 kilometers. Yes, in my staying in Addis Ababa in Ethiopia, I changed 4 cars. So it means it's easy to calculate, yeah, how many roads I covered for 2 years. So.
And you had to keep your car maintained.
Yeah, and as a rule, we have at least 2 spare tires with us, because the roads were so bad.
They had to be tires that would resist the thorns, because I remember I had to order a whole bunch of them.
But it's mysterious, but in this how to say, rural country, you can find always pieces of steel knives, yeah, and at least twice you normally change your tires before you reach destination.
Yes.
You can imagine, yeah. So distance between Addis Ababa to Debre Marcos, something about 350 kilometers or 400, yeah. So you should change 2 tires before you reach your destination.
It was rough traveling.
Yeah, it was a practice.
The thing I used to adore in Bihar, you see one of their Mahindra Jeeps, which are used to rebuilt Willys Jeeps from the Second World War. They would have problems getting correct quality of steel for the springs in the car. So you would see by the side of the road a Jeep jacked up on bricks, and someone with a hammer tempering the leaf springs and measuring them by the length of the curve with a knot in a piece of string. Just absolutely marvelous.
It's funny. Thank you so much, John.
Sorry.
No,
sorry for intervention. Sorry.
No, not at all. We have some people requesting to hear the song, so we want to have time to play that at the end, definitely. So, in the meantime, though, I'd really thank you for sharing your stories and the humor and innovation that must have gone into that time. Marie, we'd love to hand over to you now to share with us some of the documentation around the communication side of the global eradication. So please feel free to share your screen.
Yes, I will. While you were talking and telling all the story, I just have been able to grab some pictures to show you and illustrate to the audience. So that's why I was in between, but listening to horses, to cars. I will just start with a few images and then I will give you more. So I will just share my screen. I'm not really used to do that, but we'll do my best.
There we go. Should be an option
Voilà.
down at the bottom. Yeah.
Okay.
We can see your screen.
So a small quiz. Who is this guy?
Is it one of our panelists?
Yeah.
Yes. The one managing the stocks.
John.
Hey, John, it's you. Amazing photo.
Wow.
So here we have John Wickett. And you were talking about Somalia and cars. Here you are. So I think it's also good for the audience to see and put some image to the reality and to those amazing stories. And that's something I like very much because you have on the car the WHO logo, as well as a poster. I think this is in Ethiopia. And you can see a poster in the back on the window of the car. So really the outreach vaccination. And this one we were talking like, I don't think it's horse, but that's what I was just able to dig out from the repository. The campaign, the immunization, and going, in the field with horses. Okay, so I will don't talk too much. I think it's best to share some visual element. But as an intro, Sarah just mentioned, okay, I'm the head of records and archives, and we initiated a couple of years ago the digitization program for the smallpox archives. The good thing with smallpox archives, it's once the disease was eradicated, they took another initiative, which was to bring back to WHO headquarters all the archive, all the record, all the document, all the material into one single place to build up this amazing repository. So this is just a photo of the archive facility so that you can see how it looks like. We have much more boxes than that. And out of it, we have famous smallpox parchment and the famous resolution. Today we are 8th of May, so I wanted to show you that. John, you mentioned about World Health Magazine. We keep them all in the archives.
Oh, very good.
Here you are.
Yes. I have lots of articles in there.
And those were like, if we talk about communication at this time, internet wasn't there. WHO had no website, but the best way they had to communicate was this World Health Magazine, which started like a newsletter already in 1948 and ended up in the late 80s. But it was a monthly magazine with several different teams, and they were sending photographers in the field to cover different health topics, as well as smallpox. You can see it here. On the photo, we see it's a bit blurred, but we can guess which one it is. And the photographer came back, created caption, and together with the editor, they prepare a lot of articles. It was really for general public, but it was just an amazing way for WHO to communicate. So when both Bill and Robert mentioned that so much can be achieved without modern communication, I think that's a very good example. Again, the famous, Santé du Monde, World Health Magazine, which was translated in the 5 languages, and several small advocacy documents. So all those documents are part of the smallpox archives, which, by the way, have been registered to the UNESCO World Registered. So it was an amazing step.
Maria, I'm very familiar with the archives. I spent a lot of time with them.
I know. My previous colleague told me a lot about you.
Oh dear.
Yes. So this is just to show you how it was, the archives. Before we started the digitization program, we were very worried because it was just single piece of information available. Imagine in case of fire, of flooding, or even with humidity and time, We all know that paper have tendency to become yellowish and can, really disappear. So what we wanted to do, it was to undertake a utilization program to preserve the memory of smallpox. So we digitize almost 800 paper documents, 15,000 images, maps, and we still have a lot to do about other formats, which now it will be even difficult. We find some company to digitize as well, the floppy disk and things like that. So that just to show you, doing this, we started also to preserve the original file. So here on the left, it was how it was before, and on the right, we use acid-free paper to preserve the document. We really respected the provenance principle. We haven't dismantled, neither mixed the paper. We stick to the, I don't know, John, you know about it, the famous blue book inventory. So we replicate it directly, but we haven't changed any numbering, nothing. So that's how it was before. The famous red book, the inventory, the paper, and today all those documents have been scanned. And we welcome researchers together with Rosamund. They send us requests to access. So instead of them traveling to Geneva to consult the paper archives and maybe damage them, what we do, we assess all the queries and the requests, and we give them access to the smallpox archives online. So you can see here that we even scan the boxes, how it was built up at this time. So we got the exact image of the archives, but on the screen and not on paper. So doing this, in those archives, we have telex, we have document, we have map, but we have a lot of communication material as well. And this is something we preserve. I put the French version, but we have also English version. So that was the communication material used in the field to trace and communicate, to show to people how it looks like. You can see an African boy, an Asian boy. So this is what was used in the field. And the famous smallpox recognition card here. So all those documents are preserved. Today they may come up with an iPad and a screen, but with paper it works very well. Here you can see how it was used in the field. So the famous card I just showed you before, and they were showing this. But please, to the panelists, I was born at that time, but too young to know. So if you want to intervene, comment, or add an anecdote about the images I will show you, please, you just talk, no problem for me. The same here, so this is in India, going to the villages, showing the card to the population. As well here. So what they did and what we realized after doing an analysis, they were like giving a completely freedom to government or everyone to reuse the material produced by WHO, to adapt and also to translate. Okay, today we have 6 official languages, but local languages are the key as well, because I don't think everyone can speak English, Chinese, Russian, etc. So in the field, you need to adapt and you need to focus on local languages as well to ensure that the message is well perceived. So again, the famous car here used. This as well was very interesting and very simple when we say like, sometimes to designer, less is more. This is exactly the case. So the smallpox and the chicken pox, so people could make the difference. And I think you showed that picture before. So you see it here in English and here in French. Donc variole et varicelle, and to show people how it is. The same that was, sorry, I was not able, I have one in archive, but since I'm also doing teleworking, I cannot go to HQ and dig out this small pictorial guide, but this is normally officially in color. It's really strong, it's really sad, but in the meantime, it shows reality. And I think WHO, in terms of communication in the 60s and the 70s, they were not afraid to show reality, how it is. Here you can see it as well, reuse the picture provided by WHO, I think this is in Ethiopia, and then adapt to the local community. The famous one, again, that I just showed you before, the pictorial guide here. I think that's okay. Quality of that photo is not really good, but it shows no internet. So they use sometimes radio or even to reach out in the street in such a way. I have to tell you, I have seen in some country being, working for the Western Pacific. I was often in Papua New Guinea. This is how they communicate when they do outreach vaccination, also in the field. Today we use a lot of, social media and internet, etc. But there is still a lot of people with no internet. So I think we should learn a lot from also the smallpox eradication program and the way they communicated to reach as much people as possible. Again, this one, here it was in South America, so in Spanish. Oops, sorry, I go fast. Again here. I think this is in India. They were doing a lot of outreach and some demonstration with kids. They were celebrating the Eradication Week. So I think that was what's interesting as well. It's all those marketing campaigns that they were really focusing also on how, meaning the local setting, like we were mentioning, how population live, their belief, etc. So they were using that during also classes. It's a medical class. Another way, okay, like I said, no iPad at this time, but they were just putting some little cardboard. And then some example of the different poster. I think going back also to some of those advocacy material and poster WHO did at this time, and as well as the time of the World Magazine, WHO communication, they were using a lot of amazing designer, like amazing photographer as well. They were really hiring professional to think about the campaign and to have really outstanding message and very powerful. And we can see here the famous cover, the famous Smallpox Zero, this one as well. So message was strong. And I think that was Ethiopia as well. So really also to adapt CEP, the Smallpox Eradication Program, to adapt to local community, to reach out as much as people as possible. Voila, so it was, I had a bit more to say, but I think I changed my way of doing because I really wanted to show and support what all the panelists have been doing. But like I mentioned, Bill and Robert, when you said so much could be achieved without modern communication, I fully agree with that. And I think today, even today, many people, many community don't have access to modern communication. So there is a lot of lessons to learn from the Smallpox Eradication Program and the way the communication has been done.
Thank you so much, Marie. I'm sure that there are many people around the world who have no idea that these precious resources exist and all the care that's gone into keeping them safe and preserving them. So, thank you for sharing them with us.
Thank you.
David, last but not least, of course, we are very happy to have you on the call. again, not many people know that the time between the last case and the time when global eradication was declared was a period of about 2 years, I believe. So you were very much involved in that time. Could you share with us a little bit about your experiences then, and looking back now as we're in this time of COVID-19? Over to you, David.
Thanks, Sarah, and thanks, Rosamund, for having invited me today. You know, many of us in smallpox eradication were young. We were idealistic and fresh out of our training. And for many of us, it was being at the right place at the right time, which let us get involved. I myself just finished a year at the London School of Hygiene and Tropical Medicine when D.A. Henderson came recruiting, and I had the opportunity to really change my career goal, which was for clinical medicine, to go into the field in public health. And it made a big difference in my career. And I think you've heard many of the stories from others around how important it was in our formative years. At the same time, though, listening to Ghassan and to Bill talking about the Cold War tensions at that time and how smallpox eradication continued, we worked side by side, USSR at that time, the US, and many, many other countries, along with our host countries. And we accomplished a job, despite the political tensions that exist. Those same political tensions exist today, and we need to deal with those today. And really, WHO continues, as it has in the past, to be a place where people can discuss their problems technically, despite these geopolitical tensions that are going on. Today, I'm chairing a group, in fact, I chaired it earlier today, an advisory group to WHO on the current outbreak. And during those presentations that we have now twice weekly, when we decide what the best strategies might be with the WHO Secretariat, we've seen countries from around the world come in, report to us what they're doing, whether it's Iran, China, the US, or Sweden. And we know what they're doing. We're able to best advise WHO. And that's why we know so much, because WHO has been able to facilitate these discussions among ourselves. But I think the most important lesson that I learned from smallpox eradication was the power of vaccines. And you know, back in 1967, when smallpox eradication really took off, at that time there were 2.7 million people dying in the world each year from smallpox. If you fast forward today and put that 2.7 million people, without escalating it for populations, on the graph of mortality today, it's number one. And it's way above the most important second disease, which is diarrheal disease in children. So getting rid of this disease has decreased death throughout the world. But it's also prevented the use of antibiotics, because antibiotics were used to treat superficial infections in those people with smallpox. And it's contributing to the most important global problem today after the pandemic, and that is resistance to antimicrobials. But that vaccine was not a safe vaccine that was used in smallpox eradication. As you know, about 1 per million people who were vaccinated died from a neurological reaction to the vaccine, and many, many more had disabilities for life. But the risk-benefit analysis at that time was such that it was more important, it was more of a risk to get smallpox than to get death from the vaccine. And so the program continued. And fortunately, it did continue because it eradicated a very important disease. But think of history. In 1980, smallpox was certified as eradicated. In 1981, a new virus was identified, the HIV virus. And in 1985, a military recruit was vaccinated with the vaccine that was used for smallpox eradication. This recruit developed generalized vaccinia, and then 6 months later died of AIDS because he was infected with HIV and it wasn't known. Today, we would not be able to eradicate smallpox using that same vaccine because of the HIV prevalence throughout the world. So we actually, in smallpox eradication, used a tool that we had, the best possible tool, and we eradicated a disease in a window of opportunity we didn't even know existed. And that applies today with COVID as well. Everyone is waiting for a vaccine, hoping that a vaccine will come. But we do have the tools, as Bill said earlier, to really stop this outbreak and to put it under control. And that is good epidemiology, identification of cases, isolation of those cases, and contact tracing and isolating those who become sick. We have a tool. We need to be using it in the pandemic today. We need to not listen to our politicians who say we'll wait for the vaccine. We need to move ahead now and do the job while it's still necessary to do, while that window of opportunity is still open. It's still open for polio eradication also. Fortunately, HIV had no impact on that vaccine. That vaccine is still effective and safe in HIV-infected children, and we need to complete that job as well. So the message is, use the tools we have while they're still available, because we never know when the window of opportunity might close. So thanks very much for having permitted us all to reflect on our days with smallpox eradication, and also to hear many stories from many different ones. And greatly appreciated that you got us all together on this webinar. I know I speak with my colleagues on the panel. So thanks very much.
Thank you, David. It really is our pleasure and privilege to have you all on the line. I know that we've had almost 90 minutes and people's schedules are very busy. However, we have had a few questions that have come through, and it might be nice just to spend a couple of more minutes answering some of those, and then we can end potentially. I think there's a video or a song that we can share.
Oh, we can share so many things. Today, the DG is unveiling a new stamp, and we'll tell you about that after. But let's have a couple of the questions that you have from our participants, Sarah.
Great. So some of them came in over email and some came in on the chat. And if we don't get to answer all of them, I really do apologize. But actually one was more directed at you, David, as well, which was, you talk very much about the window of opportunity with regards to the smallpox and the vaccine. What was your experience with the emergence of HIV and the impact on the smallpox vaccine, and how that applies to, again, what we are learning today with COVID and to polio as well? I know you mentioned a little bit about it, but it'd be great to have a little bit more information.
You asking me?
No, David.
Sorry.
First, we'll thank Marie as well. Marie needs to also depart to another call, to another meeting. Thank you so much.
Hi, everyone.
You've really illustrated the importance of communication at its most beautiful and rudimentary, but important. And thank you for sharing that with us. We will be sharing the photos that you've shared today also with the participants on the call.
Yeah, I will send you the last minute change. Yeah. Okay, thank you, everyone. Goodbye.
Thanks, you, Marie. Lovely too.
Thanks, bye-bye.
I think potentially, I think David's camera's frozen, so we may have lost him for a little while. So we can maybe move on to another question and come back. I think many of these have actually been answered. We've had questions about what can we learn from the smallpox eradication in terms of contact tracing and ring vaccination. So I think several of our panelists have spoken to that, right?
Yeah, I can say something about ring vaccination. In terms of the concept of the ring, I think most folks, perhaps many folks on the call, are familiar with the fact that this is the way the Ebola virus disease vaccine is now being deployed. There was no vaccine 10 years ago, even for Ebola, but not even in West Africa. But now in DRC, in the outbreak that is now ending after a year and a half, the teams there are able to pursue the same strategy, finding cases, tracing, looking for contacts, and now offering this new vaccine, which has been an incredible contributing factor. But many other outbreaks were put to bed before the vaccine ever arrived. So again, it's the same lesson that we must not forget, that the basic tools are there, as David has said, as all of you have said. And I just like to illustrate an example. So we had a presentation from Vietnam recently on why have they managed to keep their COVID-19 numbers low and lower than other countries comparatively, even per capita. And what was interesting about that, because we hadn't heard this from any other country before, is that whereas most countries and even WHO recommendations are to find the contacts and to, of course, request those contacts, even if not having any symptoms or any signs of illness, to remain at home or to remain in a facility under quarantine for 14 days, the duration of the incubation period. What Vietnam has done is they've gone one step further. So they have the contacts of persons with symptoms or a positive test who go into quarantine in a facility. But then the contacts of contacts have also been asked to stay home. And in that way, they have covered 2 full incubation periods around 1 case. Of course, that makes contacts and contacts of contacts. So it's a double ring, the same way that the strategy is being used for vaccination in DRC, but it's being used in Vietnam to deal with COVID when a vaccine isn't available. And I think we can see the results. We haven't really discussed it at any great length, but I wanted to raise it as an example because it's relevant here for us today. How do we do what we did for smallpox in the context of COVID-19? And this is one example where the ring strategy is being adapted, but using contact tracing and quarantine. I thought it was a very illustrative, a very instructive example. But I would like to invite the panelists also to speak to that. We have a number of questions online as well. One of them is very general. What is the most important advice you would like to tell those trying to control SARS-CoV-2? Let's see, another bit more controversial one. Did any countries shut borders, and how did they decide to reopen? Does anyone want to take on a couple of those?
Your turn to be in the hot seat now. We can always collate them and.
I'm willing to try to respond to what's the most important thing. It's know the truth. I have to keep coming back to that we have to know the truth. I found myself after smallpox eradication unable to actually leave it. I kept thinking about how could we have improved what we had done. And for instance, now I would train dogs to find smallpox because that's something we've learned, that they can pick up so many scents that I'm sure that there's a very clear scent about smallpox that dogs could have picked up. But the other thing is, I found myself wondering, could we, if we were good enough, not have stopped smallpox even without a vaccine? And I think we could have. If we had used the contact tracing, isolated the case, looked at their contacts, isolated anybody who was sick, knew whether they had smallpox or something else, and continued to do that with a great organization, I think we could have even gotten rid of smallpox without a vaccine. So that's the lesson for COVID-19. We don't have a vaccine, but as David said, use what we have.
Thank you. Would anybody else like to make a comment on that? I think there was also a question about how did you coordinate such a large and complicated movement in the absence of what we are so reliant now in modern technology. Maybe John, you wanted to say something about that.
Well, no, I was picking up when you were wondering if the borders were closed. There was quite an interesting go around with Iran. And well, they were, it was a 2000 anniversary, I think, of the empire of Iran, and we had a smallpox outbreak just close to Tehran. And we managed to get our way around and make contact and get a report on the outbreak and the details, but it was very tricky. And I think it was Hassan Shafa who was at headquarters, an epidemiologist who was Iranian, who helped a lot through contacts, but it was an adventure, shall we say.
So I have another question from the chat. Oh, sorry, John.
Well, John, I'm glad John remembers that. It was the 2500th anniversary of Persia, and it took place outside of the city of Shiraz. And we knew there were smallpox cases in the hospital in Shiraz that were not being reported. And we actually arranged to fly in on a weekend, and I would go to that hospital for some other reason and come across these cases. And that information got back to Iran, and they reported the cases then on that Friday night.
Little subterfuge goes a long way sometimes. There's a question on the chat. Perhaps Robert, you'd like to take a crack at it, since you've have the 21 chapters from your 15 contributors. You already mentioned actually some of the notion of vaccine resistance in northern Ethiopia, I believe it was. But in general, how was the response to vaccine, and was there different strategies that you had to deal with resistance to vaccination or uncertainty about vaccination?
Right. Thank you for that question. You know, my experience was different. Even if you were to ask other Peace Corps volunteers or other Ministry of Health workers in Ethiopia who had worked in the southern part of the country, it would have been different in those areas. So it was very localized. But where I worked, you could spend all day long trying to convince people to get vaccinated. And at the end of the day, you might have succeeded in vaccinating a dozen people. What I ended up doing, because there was a famine going on at the same time, this is the famine that ended up overthrowing Emperor Haile Selassie. And what I ended up doing was positioning myself in between the people waiting for their food rations and the food, which was actually a dangerous position to be in because the food was running low. But they had to pass by me first. And I was there with my needle and with my teams to vaccinate people. So I think there was there was a very conservative, traditional leadership structure and a very conservative Coptic religious structure in the areas that I worked in the mountains in Ethiopia. And these were people who had been very much secluded from the rest of the world for hundreds of years, for thousands of years, really, because of the mountainous terrain of Ethiopia. They were quite isolated, and the religious leaders had their own explanation, as I said earlier, about what causes illness and what keeps people well, and it had a divine interpretation. And it wasn't appreciated that there could be something as simple as a vaccine. It was just too foreign a concept. And in fact, it was a threatening concept to the power structure. So people looked very much to their leaders for guidance. And if the leaders didn't think it was a good idea to get vaccinated, the people didn't get vaccinated. I had a very different experience when I was in the lowlands, in the below sea level in the Donegal Desert, where if the leader there said, get vaccinated, everybody followed suit. It was very easy to immunize the nomadic populations where I worked. But even in the mountains of Ethiopia, even if the leader said, okay, I think this fellow is on the up and up, it's a reasonable thing to be asking our people to be vaccinated. Even if the leader had said that, the people would generally not have agreed. If the leader had said, go get vaccinated. There was so much inbuilt resistance, again, in the area that I worked. And like I said, for some better part of a year, all of the smallpox in the world was in those areas where there were pockets of such resistance. So it was a challenge. Yeah.
Thank you so much, Robert.
If I could just add one more thing. In Ethiopia, the variola minor wasn't a major killer of people. I mean, the case fatality rate was only 1%, unlike with some of the other strain, serious strain of variola major, where it was 30%. So only 1% of people who got infected died. So Ethiopia in general was a government which was probably the last country, endemic country on earth, to agree to participate in the smallpox eradication program because they had and felt they had other priorities. Of course, when you talk about an eradication program, it's got to be a global solution with all countries participating. So that's why I think Ethiopia was a little bit slow to sign on.
Thank you, Robert. So I think we're beginning to see some people drop off the webinar, so I think it's our time to wrap up. We'd like to say thank you very, very much for taking the time to be here today, to talk to us, to share, to reflect, and so that we can all learn and live a little bit of that history alongside you. So we really, I'm sure I can speak on behalf of all the participants, very, very thrilled. And perhaps Rosamund will say a few words before we have a video apparently that has been made by WHO, which we can show. I think it's short, and then we would be delighted to ring out the session with John's song. So Rosamund, a few words.
Yes, thank you very much. So as you know, this was meant to be the week before the start of the 73rd World Health Assembly, which will still begin on the 18th of May, and in extraordinary adaptive fashion, as we all do when we must, it will be a virtual World Health Assembly. And so many of the events that we had initially hoped to plan for this WHA, including smallpox traveling exhibits, and the launch of the WHO Museum, those ideas for the time being are all moving online, and so there will be more information coming out about that in the coming weeks and months, and I can't put a timeline on it because we don't know exactly when that's going to be possible. But the idea is to create a virtual WHO museum which can be shared with everyone, as well as possibly a traveling exhibit on smallpox, which may go to the expo in Dubai, for example. So those ideas are still being worked on. But part of that whole effort of thinking how to commemorate this very important moment and thank all of you and everyone else who made it possible, there was also the notion of creating a stamp, and the United Nations Postal Administration has created a commemorative stamp which will be launched by our Director General, Dr. Tedros, who is from Ethiopia and has expressed tremendous interest in your stories and has told his own stories about seeing those very same posters when he was a child walking along the street holding his mother's hand. It was one of the first things I heard him say when he spoke to a staff meeting, of how one of the reasons he's at WHO today is because he remembers seeing those very same posters in his hometown in Ethiopia, and that has brought him where he is today. So he is very proud this afternoon to launch this commemorative stamp, and we didn't think we would be able to show it because it won't be launched till 5 p.m. or after 5 p.m. But we have understood now that it's available online, and so we're going to show you a short video which ends with the stamp, and then by popular request from our folks online, we will sign off with John's Variola Blues. And then that way we can just again thank you all for participating in this special event. There are other events that will be happening around the world today and through the next few weeks with the 73rd World Health Assembly, and we're very proud to be part of it, and thank you for joining us to be part of it. So let us show you. Have you got it keyed up?
One more time.
So this is the first, you are the first to see this video.
Right.
All of those who are still online with us.
Great. Oh, it's going to say again.
We have some folks who want to speak. We will share the video. It's already online, and we would like to. Do you want to take questions from the audience, or we say thank you to our panelists and we wrap up? We've kept you a very long time, almost 2 hours. We anticipated it would be long and interesting, and you've actually kept the attention of the folks online throughout. So thank you. They're fascinated by your stories and your contribution, and we will end on, if you don't mind, you may all say thank you if you like, but after that we will end on the Variola Blues. Do you want to unmute them so we can?
They're all unmuted.
Okay.
So thank you, everybody. We can all say a goodbye, and we've had a lot of appreciation expressed in the chat. So I think it was very well received.
Thank you.
Thank you.
Thank you.
Right, I'm going to try once again to share my screen and bring in, I hope it's the correct one. Please bear with me. Maybe it will.
Hang on YouTube. Can you find it on YouTube?
Yeah.
That's it. Yep.
My special hello, greetings to William Fege. I wish him really sincerely good health, stamina, and brevity as usual.
Thank you, Gasana. It's good to see you again.
Yeah.
Right. John, back to you.
The Blues is a song about the eradication of smallpox. It was written in January 1977 upon the departure of D.A. Henderson from chief of the program. And we saw the last case in Somalia in October 1977. I got those vicarious variola blues. Well, variola, baby, look what they're doing to you. For centuries now you come on strong. Now it seems you're almost gone. Variola, baby, what'll I do without you? Variola, you're old as all mankind, and it seems your existence began in a warmer clime. But after Asia had given you her best, you still had a hungering for all the rest. So you spread yourself into the Mediterranean. Now variola, you had you a time or two. Even Pharaoh Ramses just could not resist you. Hustled your way through Europe's millions, ruined all of them Aztec Indians. Shit, no matter what had you come to. Well, variola, you made it in every nation. Gave us your kid sister variolation. She wasn't 100%, but she got her due. And with all respect to Lady Montague, for a goddess you got quite a reputation. Down through the ages you had a pretty free hand. Oxy lady, content in the rate of man. But a cousin found cows his inclination, put Eddie Jenner on to vaccination, and your demise became a management plan. So they thought about it, and 200 years later, they decided that they needed a big operator. Yes, the man said CDC, who said great man like he's for free, and variola, you finally met your heartbreaker. Well, variola, you finally met a man so hard. Early on in a fight with no holds barred, you found out you've been slipped the needle, and we've been slipping money to the local people. You're being certified, it's time you were retired. I've got those vicarious variola blues, been standing watching, trying to figure who's who. Well, they tracked you down to the end of your contract. There's no more extensions, no more comeback. And after Somalia, no one's gonna renew. Variola, just have to make it without you. Variola, we're all gonna make it without you.
Great.
Thank you, John. Thank you, Gaston. Thank you, Bill. And thank you, Robert.
Thank you.
It's been a pleasure.
Thank you to all of
See
you. It's been fantastic having you with us, all the people online. And
have a good, safe weekend.
Can I just say one thing? There was a set of stamps issued around the world on the certification.
Fantastic.
So there should be a proper collection in the archives.
so there is, and that's one of the ideas with the original idea that of this stamp launch and the original exhibit that we were going to present at this time would have included also that whole range of stamps which are in the archives, some of which are in the Red Book, and that will definitely be a part of the exhibit when it does go forward.
And I have a copy of them.
Fantastic.
And I'll have to get one of the new stamps so I can complete the collection.
Definitely.
Thank you
There's
for
also medals.
thank you for organizing this. It seems suddenly so relevant to what's happening today, and I hadn't really thought about it until you asked me to participate. But it really is relevant to what the world faces now. I mean, the leadership from WHO and the great involvement of CDC, and the fact that we were all globalists then, and it made sense, and it still makes sense now.
We still have many partners and experts around the world working with us day in, day out, 24/7 since January. And WHO could not do it without you and the others that have followed you in that role. And it's really critical for us to have that global partnership, as the DG keeps saying, global solidarity amongst countries, but also between individuals. And we're all in this together, and we can only get out of it if we continue each doing our part. And that's what we wanted to portray today, the parts that you have played and what a difference it makes.
Right.
Thank you.
Thank you.
Thank you.
Thanks, everyone.
Thank you, everybody.
Thank you.
Take care.
very, very nice chance to see old friends. You see, yeah.
Спасибо.
Well, now you can organize another
It's
webinar with everyone.
really nice present, a gift for all of us, yeah.
Okay, see, nobody wants to leave now.
All right, I'm going to end the meeting, but we can do this
Okay.
again.
All right.
All right,
again.
goodbye, everybody.
Bye.
Bye-bye.